So let's go over the medications again. Just a quick run through. Propofol, its receptors. We'll talk about some cons and pros for each of these. So propofol works on the GABA A receptors, and it increases the activity from the GABA A receptors. Some cons of propofol, probably the biggest one is the decrease in blood pressure. Pros for propofol, it's reliable. It's the most commonly used medication, so we're very comfortable with the effects it has, even if it does cause blood pressure. It's no nausea, vomiting, and it's actually an antiemetic itself. And it's very good hypnotic. Ketamine works on NMDA receptors, and it is an antagonist. Cons would be delirium and hallucinations. It also causes nausea and vomiting. Pros for ketamine is very stable hemodynamics, with the caveat of potentially causing significant hypotension in someone who's very sick. And big one here is that we can give IM dosing, so that's a possibility. So for ketamine, if you have, let's say, a child who is totally resisting the insertion of an IV, it would not be unreasonable to give this screaming child induction dose of IM ketamine and then getting IV access after the patient is asleep. And this is something you simply cannot do with propofol or etomidate because these ones are IV only. Etomidate is a GABA A agonist as well, and increases chloride influx into the cell. Big con for this is adrenal suppression. So again, less cortisol and less aldosterone are being made, potentially after giving a dose of this, although it doesn't happen in everybody. And then the big pro for this is very stable hemodynamics. I would say even more so than ketamine, because it doesn't have this sometimes sort of myocardial depressant effect. So let's do some case examples. Number one will be a healthy 29-year-old female for an ACL repair. We know that she's going to be hemodynamically stable. So basically our induction goal for this lady will be to provide a smooth induction with minimal side effects. And so what's nice about propofol is that there's no nausea, vomiting associated with giving induction doses of this, whereas that is a minus for ketamine and a minus for etomidate. We know that we'll drop her blood pressure a little bit with propofol, but she's young and healthy, and she'll actually tolerate that very well. So the hemodynamic effects of propofol might actually be minimal in this patient. So our main con of propofol is not really applicable in this case. So I would say that this is a very appropriate induction agent for this particular patient. Technically, you could use ketamine, but you're risking delirium or this person having hallucinations at the induction doses and potentially causing nausea and vomiting with ketamine, and same thing with etomidate. So here it's pretty clear that propofol is a very good basic induction medication for this type of case. Let's take another example of now a 30-year-old male who is septic secondary to necrotizing fasciitis. And we know this is an emergency surgery because we need source control of this infection. This person is going to be hemodynamically unstable. And let's say that maybe they're even on norepi already, and their MAP is like 70. So what you should recognize is that induction doses of any of these three medications are potentially dangerous for this patient because they're already sick with a lower end mean arterial pressure on norepi. So with propofol, certainly there is this risk of decreased blood pressure with giving that for induction. With ketamine, you are probably in the territory here where you may be causing myocardial depression and therefore decreased blood pressure with this as well. And for etomidate, this septic population is the one that is definitely known to be more susceptible to the adrenocortical suppression. So this is probably something that we don't want to expose this patient to the risk of post-op. So let's say that this one is out in this case, and you could probably go back and forth debating propofol and ketamine, but I think that you could make the case that ketamine here is going to be the lesser of the three evils and use that as an induction medication in this instance. Let's do one last example. We'll try to make it where etomidate seems like a reasonable choice. So here we'll have a 45-year-old male who is involved in a motor vehicle accident and has a traumatic brain injury. So potentially has high intracranial pressure here, and we want to keep a very steady amount of blood flow to this patient's brain to support adequate tissue oxygenation and perfusion. So for propofol, the big risk here would be that your decrease in blood pressure would equal decrease in cerebral perfusion pressure. So the large swings in your blood pressure associated with induction doses of propofol here are potentially dangerous. For ketamine, people would worry that your increased cerebral metabolic rate and the potential for increase in ICP, although that's just a maybe, would mean that this is potentially not the best medication to be using. Certainly, if you're increasing your cerebral metabolic rate, that's not going to be in line with your goals for someone with a traumatic brain injury. And then lastly, etomidate has the benefit of hemodynamic stability, which means that you'll have decreased changes in blood pressure and therefore decrease changes in your cerebral perfusion pressure. So you will maintain a pretty stable cerebral perfusion pressure throughout induction with etomidate. So perhaps this would be the best medication to choose in this instance. I just want to end this discussion by saying there is absolutely no hard and fast rule about these induction agents, and every clinician is allowed to have their own ideas about what will be best for the patient, and every patient should be considered on a case-by-case basis. These are just some cases that may give you some insight into the decision-making process about choosing any one of these induction agents. But it's certainly not the rule. All right, thanks for watching.